Welcome back, clinical problem solvers, to another VMR RLR Friday edition. Good morning, afternoon, evening, wherever you might be. Uh, Robbie, how are you?
That was so professional. Wow.
We gotta give they come for it, we gotta give it to them, what they're coming for. So maybe first I'll ask Kashayar to unmute himself, say a few words and his role for today.
Hi everyone, I'm Hasher, medical student from Iran. I'll be doing the scribing today.
Zachariah, please follow suit.
Hi everyone, I'm Zachariah, I'm a junior doctor in South Africa, doing teaching points for the first time today. Looking forward to it.
Good luck, my friend. And Patricia, who is presenting today, tell us a few words about yourself.
Hi everyone, I'm Patricia from Cameroon, and I am an internal medicine match applicant for this cycle. So I'm excited to be here and discuss a case with you all. Thank you.
So nice to meet you. Patricia, what do you like to do outside of medicine?
Wow, outside of medicine, I like outside activities like hiking, running. I'm also a big fan of home sport, like having your all exercise set at home, and you can exercise at any day of the time. I really like home exercising. Yeah.
You get along with Robbie. He runs every single day.
Wow.
And yeah, and he loves hiking too with his best friend Nar. Well, Patricia, we're looking forward to your case. Whenever you're ready, share the first aliquot, and Robbie, our mathematician, will start problem solving.
All right. So I have 5 aliquots for you, and the last aliquot is the final diagnostics. In the first aliquot, we have an 81-year-old man who presents to the ED with altered mental status and drowsiness. You can start.
Yeah, I don't.
Robbie, before you start, can I just say one thing?
Oh, of course.
I have this incredible latte. I just want to show it to you real quick.
Whoa.
And I always wanted to do this. Cheers.
Cheers, Prof. Rez. I will. Kara is very nice, and she's making all of us. Kara's friend is here too. Matcha lattes. Mine was going to be warm, and coming up soon. So I'll cheers you back momentarily. It's unfortunate that this patient would not be able to cheer given his mental state, but hopefully we can get him to a place where he feels a little bit more comfortable. And I think that with the little information you provided, Patricia, actually it's quite a bit. And the 2 pieces of information that you provided are that he's 81 and that he's altered. And I would say it's amazing how powerful the mind is, that it often assumes one other thing which you have not said yet, which is the time course. And immediately when I think altered mental status, my mind immediately assumes acute. And that's because the vast majority of people who come to the emergency room for acute care who report this do in fact have altered mental status. But if you take a moment to prepare yourself for the unusual circumstance that this actually developed over seconds, what we'll talk about next doesn't apply. Or if you take a moment and realize actually that this patient has been confused for many years and that his family is finally saying, oh, maybe we can't support him at home and that's why we're coming to the emergency room. So I just make a note of how that if your mind is like mine, you probably made that assumption that it's acute, but it's for good reason. It's base rate. But anytime you accidentally make an assumption like that, you want to be sure that you at least verify it or study it and not keep proceeding with it automatically. I think that it's very helpful that you said he's drowsy, because whenever we have altered mental status, we realize that altered mental status comes in many different flavors. And Yusuf and I shared a case on Friday where the altered mental status was actually psychiatric in nature, and the patient's behavior had changed significantly, but his level of arousal had not. And that patient actually had a focal lesion in the frontal lobe explaining the psychiatric changes. So here, the fact that the altered mental status is that of the level of arousal, it actually makes it unlikely the patient has a focal neurological process. Whenever your level of arousal is perturbed, it's often a diffuse brain problem emanating from a systemic issue rather than a focal strategic brain problem, though there are some exceptions to that. So with what you said so far, my mind is assuming this is acute, but I want to verify that's the case. And with the word drowsiness, you're telling us that the probability of the answer lying structurally within the person's brain is lower. So in most instances, what we're going to do next is to try to get an inventory of what is happening systemically to the patient to help us get a clue of why that systemic issue may be affecting their brain. And then slowly, if we find nothing, then we will start to move closer and closer to the brain. And only if this patient is obtunded will we prioritize brain problems faster. His age gives us license to move in this manner because the probability of an extrinsic cause is also related to his age. So sum total, it's going to be a slow evaluation outside the brain first, unless we get focal neurological signs on exam or extreme drowsiness. And with that, I will cheers you, Prof. Rez, and see what other thoughts you have.
No other thoughts. I love that. Like, we're assuming it's acute with its base rate. The tempo will change it. And then the age means he's quite vulnerable to an extrinsic cause pushing him over the edge. Excited for more from Patricia.
So to give you more histories, so 5 days ago, the patient developed a mild headache and low-grade fever around 100.5 Fahrenheit, which he initially attributed to a common cold or flu. However, his symptoms progressively worsened with the fever spiking at 103, accompanied by nausea, muscle aches, and general weakness. 2 days before presenting, his wife noticed that he was becoming increasingly forgetful and confused. He struggled with words and had difficulty following simple instruction, and he appeared drowsy for the most of the days. His balance seems impaired, and he required assistance to walk due to leg weakness. This prompted his wife to bring him to the emergency department. Review of system, we don't have any upper respiratory symptom, no cough, no sore throat, no chest pain, no shortness of breath. Past medical history, the patient has AFib, hypertension, diabetes, coronary artery disease. Social histories, the patient is married, he lives in Texas, Houston, suburban area. No tobacco, no smoking, no drink. Like he drinks alcohol occasionally. He has no recent travel outside of the US. Do you want me to give more information, like the vitals, or I should stop here?
No, Patricia, I think we have a lot of juicy data to discuss. And I appreciate the way that you're presenting this case. It's really expertly being presented and sets us up for a good discussion. I'll just share my general thoughts and then ask Robbie to reflect on those thoughts and add to them. It's so interesting when we say fever and headache and we're at morning report or we're in the hospital, all of us are going to be like, oh, is this meningitis? That's the first thing that will come to everyone's mind. Does the patient need an LP? But just think about it. How often in your lifetime have you had a febrile illness where there was headache as a bystander? You didn't rush to the ED. Just several months ago, I had a viral illness, I had a headache, I had a fever. I took Tylenol. I talked to Robbie. He said, just take Tylenol. I took Tylenol. And luckily, it wasn't untreated meningitis. But the point I'm trying to make is, like, really anchor yourself in the base rate. There's other clues here where we become more concerned. Like that initial phase of this illness, which is headache and fever, I would have recommended, take some Tylenol. Maybe there's a virus because the patient has myalgias. They're really giving you a viral syndrome. But then the later stages of this illness becomes concerning. That's when they have to present to the ED. And I'm glad the wife took the patient to the ED. And that's when you actually start having altered mental status and focal weakness, which is presented as ataxia. So all of a sudden, where we thought we were dealing with a viral syndrome, the headache being a bystander, now we're really wondering, is all the inflammation within the CNS? Is this a CNS inflammatory illness? And it is true, like the same way Robbie mentioned, that someone who's this advanced in age, though, this patient, like my grandfather had the sharpest spine at 92. My mentor, my clinical mentor, Elmer, 96 years old, his mind, I'm not even joking, is sharper than mine. So it really does, we need to figure out what this baseline's mental status and functional status is. Because if it's robust, then all of a sudden we won't look at it and say, oh, this is a frail 80-year-old guy who's vulnerable to altered mental status in the setting of a viral illness. So headache and fever, it may reflect meningitis, but then once you have headache, fever, altered mental status, all of a sudden you worry about meningoencephalitis, meaning the meninges and the brain parenchyma. And then once you add potentially weakness, you can think about meningomyeloencephalitis. I don't know where you put the myelo, but you put it in one of those words. But basically, is a spinal cord also involved? So what this story does for me, Robbie, I look at his background, I see he has diabetes, he's immunocompromised. His advanced age also makes him immunocompromised. As we lose the bone marrow stem cells, get replaced by fat. I'm thinking, did he have like a virus that now is attacking the central nervous system, the meninges, the brain, the spinal cord? And if you think about it, the viruses I'm thinking about include enterovirus. You know, right now in Gaza, they're doing a polio vaccine because it's reemerging. Polio would be a very good fit for, you know, transverse myelitis and attacking the spinal cord. So I think what I do with this information is be very concerned, prioritizing infectious etiologies. Bacteria work pretty fast. Virus can be consistent with this. And I'm already thinking, what is in my armamentarium from a neurologic diagnostic standpoint? And that is CT scan, MRI, LP, and EEG. But Robbie, I'd love to pass the mic to you, just from like a 3D clinician standpoint. Like you get this on the board, altered mental status, fever, headache. How do you, like, you're going in that room, what are the must things that we don't miss? Like, how are you activating the next steps?
Such an amazing question, Prof. Rez. And you know, you guys are under the illusion that you learn more than Reza and I do when we do these cases, but that's not true, because I tried to lay out before this aliquot what would make me worry about somebody actually having a problem in the brain. And I had not fully uploaded what Prof. Rez just pointed out. And I just take a moment to re-emphasize what he said, which is how the story evolved. When the vast majority of people who come, at least that I've taken care of in my short career, who come in with fever and altered mental status, they have the cause of their fever be outside their brain, like a UTI or pneumonia. But here's what's key, which Prof. Rez taught me through his teaching right now, which is almost all of them develop the fever and the altered mental status synchronously. That patient who has the UTI, who gets confused the same day they get the UTI, or gets confused the same day they get the pneumonia. The fact that this patient was able to spike a fever of 103 and not be confused, then subsequently get confused, is very unusual. And I would say I have never seen that. And I think that would have my spidey senses up, just like Prof. Rez said. So I'm going to now upload my notes about when I'm going to be suspicious for an intrinsic issue, which is when there is a disconnect between the systemic syndrome and the brain. And when this patient initially started, he was sick, but he was not confused and developed the confusion on his wife's watch. And I think that's a telling clue. And so what would I do in the moment in the emergency room? I think that base rate would have us still prioritize an extracranial cause, in large part because we would want to avoid the distraction phenomenon of hurtling towards the brain and forgetting to pick up something that's simple along the way. So my exam would be very, very focused to make sure I didn't miss something in the lung, abdomen, or whatnot. And so I think right now, taking inventory of any systemic clues, because the distance between us and evaluating the brain is now much, much, much shorter. And in fact, it's so short that almost no matter what, you're probably going to need a head CT on this in this patient given his age, and you're probably going to need to do a lumbar puncture. The question that we'll have to discuss maybe after the exam is, do we empirically start antibiotics for this patient until we get that data? So maybe Prof. Rez and I can share our thoughts on that very important question. But the truth is, we wouldn't think about it until we laid eyes on the patient to really get a sense of how much is the history that we are hearing, how much does that match up with what we're seeing with our own eyes? And so that's, I think, an active question for us to discuss. But maybe, Patricia, you can give us your next aliquot and we can go from there.
Great discussion so far. So you asked for more information. We have a temperature and at 102.8, a blood pressure at 135/85, an heart rate at 98, respiratory rate 20 breaths by minute, and O2 saturation at 98%. General appearance, the patient is ill, appearing, and drowsy. ENT, normocephalic, atraumatic, no meningeal sign, pupils are equal, round, and reactive to light. Cardiovascular system, the rate is regular, no murmur, rubs, or gallops. The lungs are clear to auscultation, no wheezes, no crackles, abdomen is soft, non-tender, non-distended. The patient neurologic exam, the patient is not alert, unable to speak. Cranial nerves are intact. Motor function, we have a 4/5 weakness in the lower extremities bilaterally. The sensory are intact to light touch. Reflexes, deep tendon reflexes, 2+ in the upper and the extremities, diminish in the lower extremities. The patient is unable to walk, no tremor or fasciculation. Should I continue?
I think this is so rich. So maybe I can actually pass the interpretation of this exam to Prof. Rez, but answer the question that I asked myself, which is, would I empirically treat this patient for meningitis? And the answer is yes, I would probably. And so the way you go about doing that is that you want to have your empiric therapy be as close to the lumbar puncture as possible, but as quickly as possible. So the first thing I would do is I would get 2 sets of blood cultures, because if this patient has bacterial meningitis, which the LP would help us think of, the yield of blood cultures is 50%. So that's the first thing I would do. Then, before sending the patient to the CT scanner, I would give him IV dexamethasone. Giving dexamethasone before antibiotics is more efficacious to reduce the morbidity and complications from bacterial meningitis. Then he would likely receive vancomycin, ceftriaxone, and ampicillin. Those 3 medications are for the treatment of strep pneumo, the treatment of Neisseria meningitidis, and the treatment of listeria. The reason that vancomycin is added is not for Staph aureus, but for the small possibility of ceftriaxone-resistant strep pneumoniae. So he would get 2 blood cultures. He would get vancomycin, ceftriaxone, ampicillin, and acyclovir. He would probably get those 3 things in that order, because acyclovir, while viral HSV is very possible in this person, it's the least acutely deadly when you compare all the things. And as he's getting all these things, he's going to the CT scanner. And you can do this while the patient is getting in the scan. You can just pause the infusion temporarily and then getting the lumbar puncture. So the priority is to first to get the blood cultures, to not reduce the diagnostic yield, to give the IV dexamethasone before antibiotics, and then to give the antibiotics first against the bacteria and then against the virus. So that's probably what I would do in the first. Yeah, and I'll pass the mic to Prof. Rez to add to that, and then to analyze this data.
Can we just take a moment to applaud Robbie? Like, I think far too often, for good reasons, we focus on diagnosis. But if you're going to take anything away from this case, it's that 2 minutes of discussion on management reasoning. Dude, that was beautiful. Like, why we use this, why we use that. The vancomycin is really for the strep resistant ceftriaxone. Just absolutely brilliant, my friend. Do more of that, please. Management reasoning. I need it. We need it. Really, honestly, the exam, Patricia, if I were seeing this patient in real time, I would be nervous. Because, like, how can I do a trustworthy exam in someone who's so altered? I have difficult enough of a time in someone who has, clarity of mind doing a thorough neurologic exam. Like, I don't trust myself completely. But in this context, like, it would be very difficult. So I think the fever with the altered mental status just confirms that this patient's inflamed, and we're most concerned for a central nervous system process. Even, for example, if Patricia shows us a UA that has white cells, we're not running away from the CNS. The one thing to note here is the lower extremity weakness, either that's real or it's just difficult to assess the motor strength. But if it is real, it would be difficult to blame that on just, at least in my mind, maybe I'll learn after this case, to blame it just on meningoencephalitis. Like, you can't have brain issues caused bilateral lower extremity weakness. Aaron Herkowitz taught us if you have like bilateral ACA strokes, for example, or a bilateral or mass that's affecting that particular area, but it's very, very rare. So it just increases my concern if the weakness is real, that we're dealing with something also in the spinal cord, that it's not just specific to the brain and the covering, being the meninges. What would I do next? In addition to collecting the blood cultures, starting the antibiotics that Robbie mentioned, getting basic labs, the question becomes, do we pursue the CT, MRI, or LP? Well, all of us are going to do a CT first, just because the patient's altered, and we have to make sure there isn't signs of increased intracranial pressure. Then I would say next would be an LP. And I think the MRI will be difficult in someone this altered to perform, where they have to stay stable and steady for an hour or so. But we really want to emphasize practical stuff. But when I do get to doing an MRI, I would also include the spinal cord. But for now, I think blood cultures, the empiric antibiotics that Robbie mentioned, basic labs, CT, and then LP, and steroids.
Okay. So we did CBC, the white blood cell count was at 10,000, which was normal. Hemoglobin at 13 grams per deciliter, normal. The platelet was at 44,000, which were a little low. CMP was unremarkable. We did a CT when the patient came. When the patient came, it was normal, no acute abnormalities, no masses, no hemorrhages. We did the CSF, the lumbar puncture, which showed an elevated protein at 18 milligrams per deciliter, mildly elevated white blood cell at 1880 cell per deciliter with a lymphocytic predominance and a normal glucose at 60 milligrams per deciliter. So I will stop here.
Since I did a lot of talking about diagnosis, Robbie, I would love to hear, you created, I think, one of the best figures for lymphocytic phagocytosis. What's your interpretation of this, my friend?
Prof Rez and I made a rule one day that she doesn't know about because I made it and didn't tell him. A long time ago, guys, we would be on the podcast. Prof Rez and I would make schema episodes on the podcast many moons ago. And I still remember already just being in awe of how good of a teacher Prof Rez was until he taught about lymphocytic pleocytosis. on the podcast, and he just absolutely nailed it. So like, there came a time when he asked me this exact same question to discuss lymphocytic pleocytosis, but we were at Kaiser Oakland Grand Rounds, and I said, no, I want you to do it. And he did it, and he crushed it. So I think it would be a disservice for me to talk about it, Prof. Rez. But it's, maybe I can talk about the labs and the imaging, because I actually think they're very, very powerful, and then pass the mic to you. To be very transparent, one of the things that I was really tracking was the possibility of a clue in the CBC, and I'll be transparent about why you have to be very vigilant for that. So most of the time when we think of meningitis, most of the time when we think of acute meningoencephalitis from an infectious perspective, we think viral and bacteria. There's no need to entertain fungal infections, parasitic infections, or amoebic infections in acute meningoencephalitis unless they're very unique variables. So all you have to do is think virus and bacteria. Now, Prof. Rez already outlined that there's one very powerful clue for a viral process here, which is the likely involvement of the spinal cord or the anterior horn cells, which is a feature of viral encephalitis and not really a feature of bacterial disease. But there are two key things that you want to, even if you don't have that clue, because bacterial diseases are so morbid, you have to track two things that further increase the probability of bacterial meningitis. The first thing is how systemically ill the patient is. If somebody has meningoencephalitis with sepsis physiology, they have strep pneumo and Neisseria meningitis until proven otherwise. Viral causes of meningoencephalitis will very rarely leave a hectic systemic septic physiology. So the key thing on exam was to actually not just pay attention to the temperature, but the heart rate and the blood pressure. And the moment you have a prominent meningoencephalitis syndrome with relatively normal vita signs, especially if it's had 4 days to evolve, it becomes much less likely that this patient has strep pneumo or Neisseria meningitis. The one cause of bacterial meningitis that we talk about a lot that does not necessarily result in sepsis physiology is Listeria. But I think our teaching about bacterial meningitis is actually has a significant shortcoming, because we often say strep pneumo, Neisseria meningitis, and Listeria. And here you probably reduce strep pneumo and Neisseria meningitis because of the lack of sepsis physiology and think, oh, Listeria. But there's one group of organisms that needs to be emphasized more, especially in a patient who has a headache and fever who lives in Texas. And those are the family of rickettsial diseases, Ehrlichia, and typhoid. Rickettsia, Ehrlichia, typhoid. And so why was I really scrutinizing the CBC is because the vast majority of those patients will have a thrombocytopenia. And so I'm still holding my breath a little bit because 144 is not normal. And I would probably just in real life make note of that and say, let me see what tomorrow's CBC is. Because if that platelet count were 40 and nothing else changes except you make that platelet count 40, then we would be doing the patient a disservice if we're not giving them doxycycline. And notice we didn't say doxycycline up front, because part of the traditional teaching of bacterial meningitis overemphasizes the three organisms, neglecting the very reasonable possibility of rickettsia, Ehrlichia, and typhus. And so I always keep the doxy very close to my back pocket, very in my back pocket. And so we have that platelet count in red. That's the only thing to keep track of so far. So here's my advice for you all. You have an acute meningoencephalitis syndrome, and you need to pay attention to two things: how much sepsis physiology and the CBC. And both those things in combination will help you really adjust your pretest probability of all 4 types of acute bacterial meningitis: strep, Neisseria, Listeria, and their rickettsia organisms and their cousins. But lymphocytic pleocytosis, Prof. Rez.
That's such an epic pearl. Looking at that CBC and the liver chemistry test, looking at that AST and ALT, because those two are often together. And Robbie, I have to make 2 comments here. One is that you and I, we don't practice in Cameroon. So we're not as familiar with like the local infections. I mean, you might be, I'm not as familiar with the local infections. And truthfully, I would be asking someone like Patricia, if I had a patient visiting the US that presents with these symptoms, what do you think is going on? Like I remember at Hopkins, there was a guy who came in with like fevers, abnormal LFTs, and we were all like, what's going on? What's going on? And my intern, who was born in Nigeria and had moved to the US, was like, guys, this is malaria. Why are you making it difficult? And she was right. And for the next 3 years of her residency, every time I saw Cynthia, I would go like this to her. Like, I'm not worthy. But it just tells you like context really helps with clinical reasoning. And then another thing, I was recently reading about pneumonia. And you know how we send all those studies from sputum cultures to urinary antigens to sometimes blood cultures? Despite all of those testing and viral swabs, only 60% of the time we end up with a diagnosis. I don't know if anyone knows in the chat, but like how often do we actually end up with a diagnosis in a case of meningoencephalitis, despite like a full workup? Because we have to just be open to the possibility that this is a virus. I know this is a VMR, so probably a diagnosis, but in real life, like I imagine a good portion just get better, and then we just complete antibiotics for the sake of completing antibiotics. But I think this elevated protein, elevated lymphocyte count, in the context of inflammation, is really prioritizing an infectious etiology. Of course, there are other causes, which actually I don't even want to waste time talking about. I think our focus has to be infection until proven otherwise. So what infections? We were most concerned for a virus. And I think the viruses that have to be sent in the serum, you have to send the HIV PCR. And remember, HIV-1, HIV-2, there's different geographic prevalence of each of these viruses. So you want both PCRs. In the CSF, you're going to be sending, there's probably a meningoencephalitis PCR panel, and I'm not sure whether you have access to that, Patricia, that specific panel where it's like a bunch of PCR tests, but I would be curious about like HSV, HSV-1 and HSV-2. HSV-2 usually is meningitis, HSV-1 is usually encephalitis. And then the enteroviruses. And we already talked about the enteroviruses briefly, but this includes Coxsackie virus, enterovirus 71A, and polio. But the arboviruses are worth considering. Like Robbie, if this was in the US, I would be worried about West Nile virus. But there's other arboviruses like Eastern equine encephalitis, the Japanese encephalitis. And again, knowing what viruses are prevalent to the geographic location you practice is going to be quite helpful. And so in the CSF, sending the IgM and IgG of West Nile virus, I think is going to be important, and sending PCR for the enteroviruses and whatever arboviruses that you can send. I think the fact that the white count isn't that high, assuming the patient's immunocompetent, makes a pyogenic meningitis less likely, and also the time course, it's just not consistent with that. We have to be open to granulomatous meningoencephalitis. Like, could this patient have had tuberculosis and now has CNS seeding, and that's what we're contending with here? It is possible. And this is where it's important to know the sensitivity and specificities of your tests. Usually they're highly specific, but not very sensitive. So like sometimes you have to send samples over and over again to get at an answer. So I think it's a good opportunity to go through like, what would you send off the serum? Like a thick and thin smear for sure, looking for, parasites, but also sending the rickettsial workup. And then what you send off the CSF, like the PCR studies, some immunoglobulin studies. But that's sort of where I am, Robbie. I continue the antimicrobials, see what it shows. I think of those viruses like West Nile virus, enterovirus, they can leave a signature in the spinal cord, the meninges, and the brain parenchyma. Anything else, Robbie, from an infectious standpoint?
Aren't you guys glad that he took that part of the discussion? That was awesome. Thank you so much, Prof. I have absolutely nothing to add. No, what were you gonna say?
You know, I had a joke with one of my best friends in college. We both took the MCAT. He crushed the English section, but I did well on all the other sections. So we were like, hey, Mike, you only focus on English. I'll focus on everything else. And then we would say our score is like 3.6, 3.6, and that was like a high score, 36. I think in medicine, I'll just focus on lymphocytic phagocytosis. Bobby, you focus on everything else.
Your mind works in magical ways, retrieving stories from centuries ago, Prof. Rez. All right, Patricia, mic to you.
Okay, thank you so much for this discussion. Prof. Rez, the patient is in Houston, like he live in Houston, Texas. So that's why
I
I
think,
took the
Patricia,
case.
are you in Houston?
Yeah, I was in Houston, but now I was
Oh.
doing an observership there. So that's why
Wow,
I met
it took
him.
us so long to get to this point of our relationship. I wish I had done that earlier.
Okay, so for the we did a CSF viral panel, which was negative for HSV and VZV and enterovirus. We did a West Nile IgM antibody in the CSF, which was positive, and we did also an IgM antibody in the serum, which was also positive. So our final diagnostics was West Nile encephalitis. Thank you.
Patricia, I just want to ask you one question for reflecting. Do you remember what time of year this was?
Yes, it was last July.
July.
Mm,
Yeah, I mean, I think that this case is such a fantastic reminder of just how deadly and how prevalent West Nile virus is in the United States. It's if you remove HSV encephalitis, it's the most common cause of encephalitis in the United States, and it's actually present in almost every part of the US. And I think Prof. Rez latched on to the key clue early on. It is essentially the most common cause of meningoencephalomyelitis. And so the fact that this patient also had signs of anterior horn dysfunction is a very, very powerful clue. Yeah, I think if you ask yourself, what is the patient's risk factor for getting this disease? It's really his age. Many of us, including actually one of my colleagues in the ER, had symptomatic West Nile virus. The vast majority of patients, about 75%, have no symptoms at all. 24% have an acute systemic syndrome that mimics mono, and actually part of what his initial syndrome was likely the systemic phase where he actually just had a virus. And then he subsequently developed his altered mental status. And only 1% of people who have West Nile seropositivity get neuroinvasive disease, and it's almost always age-related or immunosuppression related. So for those of you who, like Patricia, love to go on the outdoors, if you are younger than the age of 60, keep going outdoors, don't worry about it. You really have to be very thoughtful about older patients or patients who are immunosuppressed, about trying to do mosquito prophylaxis, countermeasures against mosquitoes, because it can be very, very deadly. Yeah, Prof. Rez, any reflections?
No, I was just calculating your math, and it adds up 74, 24, and 1 equals 100%. But I have to way to remember. That's awesome. Patricia, thank you so much. Any reflections from you, Patricia, before Zachariah takes over?
For me, it was interesting because West Nile encephalitis, for example, is those kind of cases that we see in board exam. So being confronted like we did face to face, it was interesting. And as Prof. Rabih said, is mainly older patients which are immunocompromised are more susceptible to get like a mosquito bite. And we asked if the patient has traveled recently. We didn't find nothing in the history pointing at West Nile virus or mosquito bite, but here we have with the positive diagnostic. And actually my attending was really like searching. It was not plain it was not a plain diagnostic, so that made it more interesting. And luckily after like a week in the hospital, our patient started to improve, like his arousal started to get better, and he was at the end, he was able to speak, and he retrieved consciousness. So it was also rewarding to see that.
Patricia, I think you should present every Friday because you just upgraded me to Prof. Red status by calling me Prof. Rabih. I really appreciate the compliment. It just doesn't, I don't belong in the same category in class as Prof. Red. So, but thank you. I appreciate the honor. I also wanted to commend you and whoever did this exam because honestly, I'll just be honest. If I saw somebody this confused, I don't think I would have picked up on hyporeflexia and weakness. I think I probably would have ignored it. It's hard, but your case just reinforced how it's so important, even in a patient who is confused, and to do a good neuro exam. Because honestly, if you just ask Aaron Berkovitz, you have a patient with acute febrile meningomyelitis. What's the cause? He'll probably say West Nile right away, or as Prof. Red said, enterovirus. So you can really just, it's not strep pneumo, it's not Neisseria, it's not Listeria, it's not Rickettsia when you are confident that it really is acute meningomyelitis. So awesome job with that. That was really cool. Prof. Red, any final reflections before we learn from Zakaria? All righty. From Texas to South Africa. Take it away, my friend.
Wow, what an amazing discussion. So we began by Rabih reminding us that we instinctively tend to jump towards acute causes when the problem of altered mental status comes up. However, the timing and progression can often quite lead us away from that, as hyperacute and subacute and chronic altered mental status is very different from the mismnemonic that we're commonly taught. In addition, decreased level of consciousness generally suggests diffuse cortical dysfunction due to some sort of systemic issue, as focal brain lesions rarely will cause isolated cortical dysfunction in isolation. However, there are exceptions to this, like when the basal ganglia is affected. In addition, Reza reminded us that older patients are much more likely to have a systemic disease as a cause of altered mental status. And usually when young patients are altered, it's most likely that there is something going on in the brain. And Reza then further reminded us that focal neurological deficits generally tend to point us towards a brain-related cause, but often on exam in somebody with altered mental status, it's easy to find pseudofocality when there is actually no focal neurological lesion. Then we moved on to discussing CNS infections, and the presence of altered mental status prioritized encephalitis over meningitis as a cause, which immediately raised our suspicion that this could potentially be a viral cause of the disease. And this was especially more important when we realized that the patient had mild and subtle signs of lower limb weakness, which then further prioritized that viruses are much more likely to affect the cord as well. Rabih then reminded us that when fever and altered mental status occur together, the base rate is usually that this combination is just systemic disease with fever, as well as the brain being caught in the crossfire, and not necessarily a brain disease itself. But a key clue to this is that in intrinsic CNS diseases, the altered mental status will develop later as the disease progresses, rather than them both appearing at the onset. We then moved on to discussing the treatment of CNS infections, and the general guidelines and approach is to immediately obtain blood cultures, as they have a relatively high yield in somebody with bacterial meningitis, and then perform imaging as soon as possible, especially in those with obvious focal deficits. We then administer the following medications in sequence, which are IV steroids, followed by antibiotics, which include ceftriaxone and ampicillin, as well as vancomycin, not for Staph aureus, but rather for the small possibility of resistant strains of strep pneumonia. We then use acyclovir to potentially cover for herpes simplex as a cause. Lastly, we discussed the causes of lymphocytic pleocytosis, with the base rate almost always being viral infection, with the rare possibilities of granulomatous diseases like TB, parasites, and rickettsial diseases. In addition, other rare causes include autoimmune diseases, systemic and demyelinating, but those are usually sort of a second pass workup. We then moved on and discussed some subtle clues that somebody may have bacterial meningitis over viral meningitis, with Rabih reminding us that usually patients with bacterial meningitis that is not caused by Listeria, but other bugs will usually have sepsis physiology, which is quite unusual to be seen in viral causes. And when we look at the CBC, any sort of abnormality in the platelet count really should make us consider the possibility of tick-borne diseases, and always to have doxycycline in our back pocket. Lastly, we got a little bit of microbiology, and we discussed West Nile virus, with the vast majority of patients with West Nile virus being asymptomatic, but about 24% will have some sort of mild viral syndrome, and very rarely in those immunocompromised and older can get neuroinvasive disease. Thank you very much.
Prof. Rez, can you believe that was his first time?
No, I cannot believe it. Zachariah, that was so good. You, I think, hit every important point, including the sequence of antimicrobials, which for me was the highlight of today's discussion. Very, very well done, my friend. I don't believe it was your first time. And I'm so grateful to Patricia for presenting and Kashayar for scribing. But of course, Prof. Ravi is going to have the final words. Patricia, never call him that again. I don't want him to get used to that label.
Oh my gosh, Patricia, I hope you don't get caught in the crossfire between Prof. Rez and me. And that word is stuck in my mind because of Zachariah's excellent teaching about the brain caught in the crossfire. I'm gonna use that going forward. So nice to see you all. Happy Friday, and we'll catch you next time, okay? Bye.